Pick your questions, write your questions down so we can have a really robust question and answer session. Okay. Well, I've been advised that we can take about 3 questions. So maybe we should ask who would like to hold the card. We have a few questions. Let's check from online greetings. Those are. But when we get to that's a question. How frequent does I don't see very well again, I'm getting old. Okay, that's thrombolism occur post-myomectomy. There are measures that can be put in place to prevent it. Prof.
I mentioned methods that can be used to prevent it. When I talked about precaution methods, of course, you plan your procedure. Sometimes you even have to tell the patient to lose some weight. And of course, you give your anticoagulants. How frequent does it occur? In terms of percentages, if you look at studies, you'll say about 5% of cases. But when it does occur, it is the evolution to the process can be very rapid. So when you have patients who are predisposed to being obese patients, or when you have very large teams, it's very important to plan and prevent that. Thank you.
There are questions in the house? Okay. Let me take out and I'll come to you.
Okay, thanks, sir. My name is Victoria Shaiva. I just came in because I saw the question. So my question is, for a patient that has undergone abdominal myomectomy, for eventually the person gets pregnant, what is their chance of giving birth through here? Since you said abdominal myomectomy is a large count abdominal wall.
Thank you very much for your question. Abdominal myomectomy, depending on how the procedure was, how big the fibroids are, or what was the preference of the surgeon, they actually leave a big or a small canalization. Most times when you don't reach into the endometrial lining of the fibroid, that means you still have subsequent fibroids. You don't break down the endometrial lining of the fibroids, or you don't remove too many fibroids. If you have to take out so many fibroids, you're going to leave a lot of gaps which you have to close down. So that's why I said after surgery, the patient's doctor should be able to advise the patient on how to subsequently do that. Sometimes when you have reached down to the endometrial lining, or you have very large fibroids, you advise the patient to do that. Because you don't want that woman going to labor and have to contract and then it breaks down. But in about more than 60-70% of patients, they do have about vaginal disease. So it's only those that have this kind of situation. And you know now too, we're having women who are doing myomectomy very late in life. 40 years, 41 years, 50 years, that they're pregnant. So some of them have already had a history of fertility. So sometimes it's special consideration for these patients. You marry for like 15, 20 years, and you want to go to labor. You come into labor when I'm not around or somebody's around, and you go to labor for labor. Labor is the most dangerous value to go through. So you offer them a section. Thank you.
Don't go. We have one from online. It says, in the case of frozen pelvis, what else can be done?
Yes, if you have a frozen pelvis, of course, in a place where you have a multidisciplinary approach, so you can have a general surgeon, you can have your urologist, you can have other specialties who can be invited to join you as surgeon and gynecologist. So sometimes, most times when people open, you can ask children where you know you're going to engage, you're going to probably experience that. So you get your general surgeon, and you invite them to come out and give you a patient. So you have to take out the moving intestines away and mobilize them. Sometimes they are afraid of the ureters because they're coming from the kidneys, you need your urologist. About 80% of cases, people don't have a ureter. So when you plan your surgery, and of course, one thing that usually helps is that you do if the patient has done a surgery outside, which is have a troublesome surgery, you can do a magnetic resonance imaging intervention to know exactly and to know which result.
We have one question here, then I'll come to you, Madam, then we'll freeze the questions. It says, is there any injection or drug that can shrink the fibroid?
I mentioned that too. You have your gonadotropin invasive hormone analog that I said are very expensive. Sometimes you can even use them to shrink the fibroid and the patient is symptom yes, okay. But we have very, very large fibroids, once operating, give these drugs for a period of 6 months. I'm sure when we're going to talk about laparoscopic approach, you see that those drugs can be given sometimes make that easier.
One more question, then we take the second presentation.
Thank you, sir. I'm interested in the adenomyosis you talked about. I remember a particular case, the lady in my throat had fibroid surgery twice, and she later came to UCH and she was told that she could never have a baby. And then the consultant she saw talked about, oh, you had fibroid surgery twice, so you can't have the baby anymore. And then he started to talk to adenomyosis.
Yeah, adenomyosis are proliferation of the mammalian lining of the uterus. So they don't really have a capsule, or like fibroids, they have a capsule, they're delineated. They can actually, like if you try to imagine eating a walnut, the inner part is what you get, the fibroid. So there's usually a capsule, but adenomyosis is not like that. So sometimes, like I said, the symptoms are the same, they look almost the same on ultrasound in some cases. So you find out that if you have to excise them, you may not leave much of the lesions behind. Because just keep on removing and cut. I remember when I met as a junior resident and we got in there and we just, of course, those days we have very good scans. So we just got there and it was at the house. By the time we finished, I was asking my boss, what do you have left here? They have almost removed the whole uterus. Because you probably start surgery and don't even know what you're doing or what you're going to see. So it's a troublesome thing, yes, thank you. But they look like that.
Dr. Brian, one comment from you?
Yes, this question of having so many fibroids and having them removed is just what I wanted us to talk a little bit about. Because those of us who do IVF, we come across some patients. Because also I'm involved, I've done something like that before. That you see that the only reason why they cannot even get pregnant through IVF is because the doctor has gone to remove like 40 fibroids and has deformed the uterus so much that she can't even get pregnant anymore. So I think we need to start this balance of trying to get every fibroid out so that we don't actually do more harm to the patients. Because if we want her to get pregnant, if that is the whole thing, then we should also get that in mind when we're doing the surgery.
I stand with you when that comes, as far as that is concerned, that you discuss with this patient, what do you want? Do you want to have children or do you want to have your fibroids totally removed? There's no doubt that we know the kind of fibroids that will compromise fertility. Sometimes those other big ones they are chasing may not actually compromise fertility. But the way our patients are, patient satisfaction is key. When you do a surgery for a patient, especially when you want to have a very huge stomach and 36-week size uterus and heart can hardly move around, sometimes the cosmetic is what satisfies the patient. And sometimes you have to strike a balance between that. Because a patient may not be happy that, oh, I didn't even take that out. But sometimes you can do less invasive techniques, like you said, that can make that woman have conceive. And of course, if she conceives, then she can always decide later on to come back and say, okay, I want to clear everything so that I'm free of those things. So yes, most times you have to strike a balance between what the patient wants and what it's going to be. Thank you.
Prof, just 1 minute. It's a related question. Is it advisable to do myomectomy during CS in terms of coexistence?
Very controversial topic, and something that has happened that's destroyed a lot of gynecologists who think they can get away with it sometimes. I think if you are, because of the way the uterus goes through pregnancy, the anatomy is sometimes disillusioned by what you see. So you think you can easily just get away with it or nothing. But what I advise people is that if you have a fibroid in your way, I want to make a scar, I want to do a lower semester section, there's one to stop in my way. I can take that one out and do it. But to take out the baby and start meddling and moving and moving. In about, I know my colleague, Dr. Mubodi is here, he probably has better figures than me. About 50% of patients, I don't know sir, if you agree with me, that patient is not in that place. The guy was completely. So it's better you just have it. Thank you very much.
Thank you very much, Prof. We'll come back to these questions on open myomectomy after when we get to the proper question and answer session. I'd like to now call on Dr. Victor Ajayi. You know, we have two Dr. Ajayis in the house today. So I'll call Victor 1 Ajayi. And he will be talking about the minimally invasive techniques of managing fibroids. Thank you very much, Dr. Victor.
Thank you very much. Thank you for that. I'm excited to be after some time. I've seen some. I've gotten away from the hustle and bustle of Lagos. So I'll be talking about the modern management of fibroids. Basically, I'll be talking about minimally invasive methods. Professor Emako has done a very good job talking about open myomectomy. But the trend these days is to treat fibroids, using minimally invasive methods. So the less we can cut, the better. As we'll see in this presentation, that will reduce complications. So I'm going to introduce the topic and then talk about types of fibroids which have been mentioned. So I'm just going to run through some of the symptoms, when to treat, treatment options, focusing on minimally invasive methods, and then we'll conclude. So fibroids are abnormal growths in the womb or the uterus. They are not cancerous. Okay? So 99% of the time they are benign. What we mean by that is that they are not cancers. Okay? They originate from the smooth muscle of the uterus. It's the commonest tumors or growths that are seen in women of the reproductive age group. Okay, many of us who are gynecologists know that this is one of the main reasons why women present to the gynecology clinic. The incidence varies depending on what study you are looking at, where you are practicing. In this part, there's been estimates of 30 to 70% of women having fibroids. So there are many women moving around, they do not even know they have fibroids. Sometimes it's an incidental finding during just a pregnancy scan or a routine scan, or even at delivery. Cesarean section, someone asks that question, just see a fibroid there. We do not know the cause of fibroids, unfortunately, up to now, but there are risk factors that have been associated with their development. One of them is just being a black woman. It's been said that black women may be about 3 times more likely to have fibroids compared to Caucasians. Why that is the case, we're not certain. Is it genetic? Is it the food we eat? I remember I spent about 3 months in India, and the largest uterus we saw with fibroids was just about 12 weeks. 1 or 2 fibroids. But here we see fibroid that looks like pregnancy at 6 weeks. We see 40 fibroids. Prof just said he removed 150 fibroids. So the black women are more likely to have fibroids. Age, the older the woman gets, the more likely she has fibroids. So, like the picture shows, as the woman gets older, you hardly see it in women 15 to 25, but as you get older, the incidence of finding fibroids increases. We did a study which we reported in 2017, looking at fibroid, their sizes, numbers, and all that. And the mean age of the women who have fibroids is about 38 years. So that is when they are likely to present in the 4th decade with fibroids. Infertility also, we've also noticed that women who are not getting pregnant are more likely to have fibroids. Again, exactly why, maybe we cannot really say. People generally say that the womb, the uterus that is not getting pregnant compensates itself with fibroids. Okay, so this study, same study also showed that women who had never been pregnant, primary infertility, were more likely to have larger fibroids, size-wise, and then the number of fibroids were larger than those who had been pregnant before. So infertility is also linked to fibroids. Whether one causes the other or vice versa is not so clear, but we know that fibroids do not generally stop conception, except in certain cases. Location, maybe when they block the fallopian tubes, or the type we call submucous that are inside the womb and will prevent implantation of fertilized egg or embryo. It can also lead to miscarriages or recurrent miscarriages. So fibroids are named according to their location. The type we call the subserosa, it's like sitting on top of the uterus. Okay, most times those ones don't cause any problems. But if they are very big, they may cause pressure symptoms, they may cause problems. Maybe they are pressing on the bladder, the frequency of passing the urine, or just some discomfort. Or the tummy may also be enlarged, cosmetic symptoms, if I may say. Then you have the one in the muscle of the uterus, which is called intramural. So those ones also can be problematic. The submucosal type, these ones are sitting inside the womb where the baby is supposed to grow. So those ones can cause heavy periods. They can stop pregnancy from happening, or they can also lead to recurrent pregnancy losses or miscarriages. So the previous one I showed, basically we use that to talk to our clients, our patients, but in the gynecological field, the figure classification is shown there. This can help you also to plan the type of treatment you want to do for the patient and then to forecast what the approximate what the outcome will be. I won't dwell too much on that. So symptoms of fibroids have also been explained by Professor Michael, but I'll just run through some of them. Heavy menses is one of them. Painful periods, abdominal pain, pelvic pressure, just feeling heavy in the lower abdomen. Urinary symptoms, when it's pressing on the bladder, that can also make the woman go more frequently to the toilet, or she can also even have urinary retention where she cannot pass through. Then the cosmetic one, the enlarged abdomen, you can see that woman in the picture looks like she's pregnant. Many people in our practice sometimes you see women who say, I've been pregnant for 2 years, it's likely to be fibroids, which have been there and can be mistaken for pregnancy. Rarely, like I said, infertility can be a symptom or the complication of fibroids when they block the fallopian tubes or they are submucosal. So, should we always treat fibroids? No is the answer. There are fibroids that should not be treated, really. They are not causing symptoms. Sometimes I'm afraid to tell a patient, you have a fibroid, it's 2 centimeters. She will call me that night. When the fibroid is 5 centimeters, we should consider, or larger, we should consider treating such fibroids. The argument is that there's what is called, I have a bias for fertility, so permit me if I go there a little bit. So there's what we call the junctional zone, just beneath the lining of the womb. It's very important in implantation when we transfer embryos. So it's thought that fibroids that are up to 4 or 5 centimeters are likely, because the uterus is really small, maybe maximum anterior posterior diameter, maybe about 5 centimeters. So you already have a 4 cm, 5 cm fibroid. It's likely to stop that junctional zone. And so when you put embryos inside the womb, the chances, even in natural conception, the chances of that embryo implanting really affected. So such fibroids we may have to remove. Location of fibroids. All fibroids that are inside the womb, submucosal, where the baby is going to grow, should be taken out. Okay. Then sometimes the fibroid may also obscure the ovaries. Because in IVF, for instance, we collect eggs through the vagina. There's a needle that passes through. You can see that red arrow. I'm not sure. Don't have a pointer again. Okay. Anyway, you can see that red arrow from the vagina to the ovary. You can see that it has to pass through, the needle has to pass through that fibroid, liver subserous fibroid. So that fibroid, sometimes you don't even see the ovaries, and then there's no way you can collect eggs. So such fibroid also, though it's subserous, you might advise the patient to take it out before going ahead. Fibroids that are distorting the endometrium, the lining of the uterus when you do a scan, or what we call the sonohysterogram, we may advise that those fibroids should come out because they're likely to disturb conception. And then symptoms, when there's heavy bleeding, when there's pain, sometimes just because the abdomen is bigger than usual, you may advise that those fibroids should come out. Or you anticipate that there's going to be symptoms. So there are cases where this fibroid is big, she can get pregnant, but she might have pain in pregnancy, which most of the time is easily managed. Or the risk of miscarriages, you have to factor that in, and then may advise that she has the fibroids taken out. So, like I said, some fibroids should not be treated, and this is a message to my colleagues, doctors, also patients must know that sometimes treatment does more harm than good. So we need to be sure that fibroids have to go before we intervene. Okay, so open myomectomy has already been discussed. It's one of the options to removing fibroids, treating fibroids. But I just want to say that sometimes this open myomectomy and also other traditional methods, we've had patients who insert some caustic substances in the vagina, saying they're trying to treat fibroids. This can do more harm than good. So in the study we did, we reported the risk factors for intrauterine adhesions. We studied patients who presented to us for infertility and had hysteroscopy. And we discovered that about 60% of them had one problem or the other inside the uterus. And the leading problem in 30% of them was intrauterine adhesion, scars inside the womb. And this scar can disturb pregnancy from happening. And when we asked them, what did you do before presenting to us? Majority of them did open myomectomy. There was B&C, evacuation, and then there was cesarean section. But the leading risk factor that we could identify was open myomectomy. So it's one of the things that can lead to, for instance, we're talking about removing 150 fibroids. Sometimes when you're doing those procedures, you cut into the inside of the womb, and that can cause scarring. So that can be a problem affecting implantation, can lead to miscarriages, placenta problems in pregnancy, and bleeding. Sometimes I saw a patient, I think just a few days ago, the womb is all scarred. We've done hysteroscopy. We now are talking about surrogacy. Someone else carrying the pregnancy. We've had like 2 open myomectomies. So we need to be careful. So now talking about the minimally invasive methods, I'll start with the laparoscopic myomectomy. Basically, it's also known as a keyhole surgery. Okay, so what it means essentially is that you are looking at, it's like looking into a room through a keyhole. You have not entered the room, but you can see virtually the whole of the room. Okay, so that's what laparoscopy does. It is a method of carrying out an operation without making large incisions. So you are making incisions, cuts are just about 1 to 1.5 centimeters in the abdomen. You are passing special instruments through those cuts and then operating with them. Okay, so it's like operating with longer hands. You're not opening up the abdomen, with large incisions. So that's, and then when you do that, you pass a harmless gas, carbon dioxide, into the abdominal cavity to create space for the surgeon to work. And then instruments can be passed in, and such instruments can be used to operate and take out fibroids. So this picture is also showing what I've just spoken about. That's the gas-filled cavity there, that's the uterus there. So you can operate with those instruments without going into the abdominal cavity. Okay, still talking about laparoscopic surgery. Okay. So there's a viewing equipment, there's a screen where the picture is displayed.
on, and so you are looking at the picture and you are carrying out the operation. It's also, there's a clear image that shows that, so you can add more what we call port sites, sometimes 3 or 4 port sites where you can, operate through and also take out the fibroids when it's done. So this picture also is showing how the operation is going on. You are operating with those instruments. You are watching the inside of the abdomen or the pelvis on the screen, and you are carrying out your operation. In our own practice, I think Prof mentioned it. In our own practice, we use generate ergonomics to shrink the fibroid. But we're shrinking the fibroid not to say that's the end of the treatment. No, because when you stop this medication, the fibroid will come back. Sometimes even more aggressively. There's what we call a rebound growth. Even these 3 doses we're giving, they have to be back to back. Okay, we're using it to shrink the fibroid to make the surgery easier. Okay, it also does, has an advantage in those who are having heavy period. If you stop the bleeding, and then they can be free of those symptoms, maintain their PCD preparatory to surgery. So we do 3 doses back to back, and then we schedule the surgery to take out the fibroids. Of course, usual preparation before surgery, last oral intake 10 p.m. before. Oral preparation is also very important. It helps to reduce the risk of injuries during the procedure. So basically, when the fibroids are taken out, we take them out by what we call moscillation, because sometimes you wonder, such a big fibroid is taken out, how does it come out? So there's a special machine or instrument called a moscillator, and you use that to slice the fibroids. If I may say, like French fries, strip them like that and then take them out from the abdomen. So the wound closure, I also want to mention that this is one of the things that also give an advantage to laparoscopic myomectomy. We use it's like a glue, a bond, dermal bond. So we use that to close the skin wound. We're not doing stitches, we're not doing staples. So the wound comes out very beautiful. Okay, as you can see, if you compare the wounds or the scars from open myomectomy, the last 2 to my right, they are not so fine, especially that last one. But for laparoscopic myomectomy, you can hardly see any scar. And I'm sure this woman will be happier with her doctor than the last patient there. She can wear her bikini, and so even the other panel still may also use a bikini, but I'm sure this man will be happier. So one of the advantages of laparoscopic myomectomy is less scarring and better cosmetics. So we've done over 100 cases of laparoscopic myomectomy and counting. It's minimally invasive, less scarring, like I mentioned, better cosmetic appearance, shorter hospital stay, 72 hours they are home. In fact, the full stay in the hospital is just the day of the surgery, they're in the hospital, then of course the next day they stay the full day. By that 3rd day, they are back home. So quick return to activity, in a week or so, they are back to their activity. Less blood loss, okay? We hardly lose blood for laparoscopic myomectomy. So most times there's no need for blood transfusion, and we reported that in one of the studies we published. So there are generally fewer complications. Yes, there are some drawbacks. There's no procedure that has no negatives or drawbacks. Longer duration, so sometimes might take longer, especially in our part of the world where we see large fibroids, many fibroids. Those can be technically difficult. And then sometimes you may need to convert to open surgery. But most times if we convert, it's a mini laparotomy, just a small incision to take out the fibroids. If we have larger fibroids or the numbers. But patient selection is very key. That will reduce a lot of this need for conversion. Also may be technically demanding, so it's not everybody who can do laparoscopic myomectomy. There's need for training for that. Risks, like all surgeries, said, anesthetic risks, risk of infection, some minor side effects after the surgery, nausea, vomiting, sore throat, shoulder pain because of the gas that's been passed in the abdomen. But most of these symptoms or complications are short-lived and do not require any specialized care. Injuries to bowel or vessels around can happen, and then they require open surgery. But when you select the patient well and you prepare well, and then you are skilled, then these are like unlikely to happen. So there's the cousin of laparoscopic myomectomy that we call the hysteroscopic myomectomy. This time, this is going through the vagina to take out fibroids, but it can only take out fibroids that are submucosal, the ones inside the womb. It cannot take, because we get this question a lot from the client, oh, you've done a hysteroscopy for me, I'm still having fibroids in the muscle of the womb. Yes, because hysteroscopy only takes care of fibroids that are inside the uterine cavity, the submucosal type, as shown in the picture. Okay, so this is the hysteroscope, the instrument that goes through the vagina. So in this case, there's no cut at all. The instrument goes through the vagina, into the uterus, and then localizes the cervix, identifies the fibroid, and then we resect it, we take out the fibroids, and then they come out in small pieces. Okay? We've done over 4,000 hysteroscopies and counting. So this is a picture of a submucosal fibroid, okay? As seen at hysteroscopy. These are submucosal fibroids. Those growths there are inside the womb. You can see that if a baby is supposed to grow there will be no space. Or if the fibroid will be competing with the baby for space, and it can lead to a miscarriage. Okay, so our previous studies also showed about 15% incidence of submucosal fibroids among our patients, over 1,000 patients that were reported. Okay, so like I said, no cut. This is the same day discharge. The patient walks in that morning, and we don't do it under general anesthesia. Goes home after recovering from anesthesia. So the same day procedure. There are fewer complications like scarring of the womb. Okay, so when we do surgeries and we breach when we do open surgery and cut into the endometrial cavity, we breach that can lead to adhesions. But when we do submucosal fibroids using hysteroscopy, the chances of adhesions are reduced. But we also have measures we take to help to prevent adhesion formation, which include putting a coil inside the womb when we think we need that, and then we place the patient on estrogen medications and progesterone, and that can help to reduce the risk of adhesions. I will mention this other method called uterine fibroid embolization. It's also minimally invasive, does not require any cuts or surgery per se. The idea behind this is just to block the blood vessels that are supplying the fibroid. So when the fibroid is starved of blood supply, it will die off. Okay? But again, because I have a bias for conception, fertility, and pregnancy, I must say that for women who are trying to conceive, we usually do not recommend uterine fibroid embolization. In fact, a couple of weeks ago, we saw a client from the UK who had this procedure some years ago. Her FSH, follicle stimulation, was 30-something, very high. You know, but when we stimulated, there was no response, no follicles at all. You know, so it could be attributed to the uterine fibroid because sometimes it also blocks the vessels that supply the ovaries, and that can, limit her ability to produce eggs by herself. So I'll just mention this. Dr. Bayomi Ajayi will be talking about it. This is totally non-invasive. I spoke about minimally invasive, and I said the trend is towards minimally less invasive method. So now there's what is called the high intensity focused ultrasound, which is the new thing now in terms of fibroid management, where you don't even make any cuts at all. It's a big case, and Dr. Ajayi will throw more light on that. So important considerations, I would always mention that patient selection is key for laparoscopic myomectomy, for hysteroscopy, especially laparoscopic myomectomy. So you have to look at the size of the fibroid, the number of fibroids. Okay. We take fibroids up to 24 weeks. You actually take it even bigger, but of course you have to individualize the cases, depends on the number of fibroids also. And also other what we may call comorbidities in selecting the patient. Previous open myomectomies also will not take midline scars because the intestines may be plastered just behind the scar. And when you're doing your laparoscopy, you may injure the bowel or the intestine. Of course, trained hands is very, very important in deciding to do laparoscopic myomectomy. So sometimes you might need open surgery. So you can look at that picture, you can see there's so many fibroids, the size and all that. So sometimes some patients may not qualify for laparoscopic myomectomy. They may have to do open surgery. So I will conclude by saying fibroids are common among women. Their presence sometimes cause symptoms, and therefore they may need to be treated in such cases. But when they are asymptomatic, there's no problem. Fibroids are better left alone. Okay, so when possible, when we have to treat, we should use minimally invasive or actually non-invasive methods, because that is the trend is currently, not just because it's a trend, but it is the outcomes have been shown to be better. Thank you for listening to some of my references. I will stop here so I can take questions.
Good evening, sir. Thank you for the presentation. My name is Dr. Guru Rajis. I'm from Zoe Hospital. And when you were doing your presentation, you made mention of laparoscopic myomectomy and hysteroscopic myomectomy. I got confused. I want to know, does the choice of a procedure determine the size of this myomectomy?
Yes, the sites. The fibroids that are subserous or intramural, the only way you can approach them is by laparoscopy. So they are for laparoscopic myomectomy. Okay, but when you have some mucous fibroids, the best approach is to go hysteroscopically. Okay, so yes, site is the location is a factor in determining the option you are going to recommend to the patient. You have a combination sometimes of all these things. Yes, we've had cases where we do both in the same city. We can take out some mucous fibroids hysteroscopically. We can also take out the other one laparoscopically. Sometimes we also have had cases where the bridge we're talking about of the endometrium. Sometimes you have fibroids that will pursue right into the endometrium because of their location. The standard practice we do in our center for those who want to conceive is that after laparoscopic myomectomy or any other myomectomy, whether open, 3 months after, we do a hysteroscopy, diagnostic hysteroscopy, to check for addiction and then patient fits go on the idea. So yes, location is a factor in determining what option of surgery you have, laparoscopic or hysteroscopic myomectomy.
Don't move because there are still questions. Wally? Online questions. Online. But the point is that
My eyes are better. How long do you generate for before myomectomy and duration between the function of the and the day of surgery? Okay, so minimum 3 doses. Okay, minimum. So a lot of people have had 4, 5 doses, but minimum 3 doses. And we want the general economist to still be active. You know, it lasts for 28 days. So it should still be active up to the point of surgery. So this is what I mean. For instance, if you had your 10 dose now, and your surgery is going to be, say, 30 days later, okay, we still recommend that you take a 4th dose just before the procedure. So we want it to be, back to back and still be active or effective at the time of the surgery. So 3 doses back to back up to the surgery time. You mentioned about diet as this factor for fibroid. What are the diets that I really don't know. I just said that is it our diet? It's a question. Okay, maybe a lot of carbohydrate that we maybe or anything that may be rich in estrogen, I don't know. Again, the cause of fibroids, these are just speculations, really. So we cannot say this diet or that diet. But maybe we need to study that if it's possible. But I'm sure there will be a lot of compounding factors. We cannot zero down on any particular diet. And doctor prescribe when I'm using hormone to treat the fibroid even if it's not causing any symptoms. No. So if it's not causing symptoms, like I said, leave the fibroid alone. If it's because of size and that size is a problem, then you need to take out those fibroids or do something about it. One of them is hypo, which we're going to talk about. Generic agonists only should be used to postpone surgery, or to plan for surgery, not to, because once you stop the drug, the symptoms will return. Okay, so not something that you just prescribe for the sake of it. Polyps during ultrasound. Polyps usually, yes, you may be able to differentiate, but it can't be conclusive. You can suspect polyp. There's also what we call a sonohysterogram, what some people call an alpha scan, which can also give you an idea whether you're looking at a polyp or a submucous fibroid. But we know there's a picture I showed that we have said that if you have a pedunculated submucous fibroid, it will stop. It resembles a polyp. So for the definitive diagnosis, you have to take histology and then it will tell you exactly what it is. You can suspect that, okay, this looks like a polyp, this looks like a submucous fibroid. But to make a concrete diagnosis, you need histology after taking it out. Thank you for the lecture. Please, what is the standard regarding use of HSG before or after open myomectomy to rule out other causes of infertility? Considering both the surgery and fibroid can cause. Well, when you're evaluating a patient for infertility, one of the things to do is the HSG. So it's part of the things to do, or at least tuber patency test. You need to do that before making a decision on what is causing the infertility. Please, I didn't get the answer to my previous question on pregnancy with coexisting symptomatic. I think Prof has answered that we should not, the general advice is not to touch such fibroids during a cesarean section because of the risks. If that is what you asked, yes, we should not. But if they're also saying that fibroids can coexist with pregnancy can go well, and there's nothing to worry about. You just have to monitor properly at the antenatal clinic. What is actually the advantage of laparoscopic surgery? Does it lie in the avoidance of disease? No, the other advantage is less bleeding, less addition, scar formation is less, quick, faster recovery time, and return to activity, less bleeding. The scar is also one of the advantages. Okay, the less scarring. How much does such? I don't know the cost of it. I would have the people responsible for cost tell you. Okay. For a doctor's wife, it's the same. We'll get back to you on that.
Okay. Thank you very much, Doctor. We'll take a short break from the questions so that we can take our third presentation, and then we'll have a slightly more robust question and answer session. Thank you very much, Dr. Victor. And I'm sure most people in the house are here because of one thing, because quite a number of people here know about open myomectomy, a few people know about laparoscopy, but I'm sure many people around the world don't know about non-invasive methods of managing uterine fibroids. And I have it on good authority that the next speaker would like to look at him the way we look at the one man who discovered America. I've forgotten the man's name now, but But I'd like to call on Dr. Abayomi Ajayi, CEO of the Fibroid Care Center by Nordica, the only center in West Africa that has this capability, and maybe the third in the whole of Africa. So we'd like to call on you to speak about non-invasive methods of managing uterine fibroids. Thank you very much.
Well, thank you so much. It's always a great privilege and honor to see your colleagues and to create time on a Saturday afternoon to be here with us. You know, when I see professors, I bow and tremble, you know. And Dr. Kolade, of course. So we're going to be talking about non-invasive management of uterine fibroids, specifically high-intensity focused ultrasound. Well, I bring greetings from the Fibroid Care Center, which, like Honora said, is the only center that has the active machine in West Africa for now, and hopefully we'll be able to get other people to be interested in this, and there's a third in Africa, one in South Africa, one in Egypt. Well, I'm not going to go over some of these things because one advantage is that I'm speaking after two wonderful speakers. So they said a lot about some of my slides, so they've rendered this to be of no news anymore. So I'm just going to skip over some of them. But Dr. Victor Ajayi spoke about when to treat. What I'm going to look at is what are the factors to consider when you want to treat fibroids, which is what the doctors consider. What are they thinking about? Well, they think about your age, you have symptoms. They kept saying it. Do you want to get pregnant? And where are these fibroids? These four things are the things that doctors look at. The age that we had only one way of treating fibroids, I think is gone. So there are many ways of treating fibroids now, and these are the things that doctors want to consider in order to see what option or options are available to you. So my presentation is to probably take us from the present to the future. Let's be able to look at the future. And I believe that the future of fibroid treatment is HIFU. I'm going to try to do that in the next couple of minutes. But this HIFU technology is a highly destructive technology. I think from what we are seeing now, it's likely to be a complete game changer in the treatment of fibroids as time goes on. Well, some people ask me that, oh, why are you bringing a new machine to Nigeria? No, it's not. Because the first HIFU machine, the first commercial HIFU machine was actually launched in Europe in 1994. And I think year 2000, the USA, the FDA in the US approved it as a form of treatment for fibroids. Well, this is the machine that we have now. This is JC200, this model. This is, okay, maybe when we get there, I'll talk a little bit about HIFU. And this is available in about 29 countries all over the world now. And Nigeria is just one of them. What is HIFU? I think that's where this question is. Well, HIFU is high intensity focused ultrasound, and it is a non-invasive technique that uses non-ionizing ultrasonic waves to hit or ablate tissues. What this just means is that it is ultrasound. Now, you focus the ultrasound, and then it gets to a point that hits or it burns the tissue. And if you look at this, I don't know, as kids, we used to play with magnifying glasses, and we called it, we say we want to do magic. You call your friends out, and you have this magnifying glass, and put a piece of paper on the table, and at a particular distance, the paper catches fire, and you say, but if you move it away from there, you see that the fire stops. So it's the same principle that the HIFU machine works on. It converges now this time, it is ultrasound, and then it hits the tissue to a point, and then it ablates or kills the tissue by thermal energy or burns it off. So how does HIFU work? That's what I've tried to explain. That you have a transducer that concentrates ultrasound rays at that point. The focal point is the only point where it burns. So all the other surrounding tissues are safe. Actually, you can put your hand in between, it does not burn your hand. Because it's only at that distance, that focal point, that the burning occurs. What are the advantages? Why do we want it? It's a day procedure. You come in the morning, the procedure lasts about 2 hours. We observe you for another 2 hours, you are home. Within 48 hours, you can do anything. You return to your normal life. Actually, we had a patient, well, I don't recommend it, who traveled. She came from America. 72 hours after, she caught the plane and went back to America. She didn't tell the people. The only problem is that she happens to be one of my classmates' wives. And so the guy was always in contact with me. But I knew the guy had gone back to America. So when he was contacting me, I said, talk to your doctor now. Why do you? And he said, oh, I'm just telling you because my wife is on the flight. She's on her way back to America. And that's how I got to know that the woman had come back to the States. So it is completely uterine sparing. You don't have any problem about the uterus. It spares your uterus, it only burns the fibroids. And therefore, that means you can have vaginal delivery in future pregnancies. It does not affect we don't have to bother whether you breach the endometrium or the endometrium was not breached. You don't need any general anesthesia. What we do is that we sedate you, but we want you to be able to talk. Because you will see as we go on why it's important for you to be able to talk to the doctor. And because of that also, there's faster recovery period. You can return to work within a few days. And then what we're using is not ionizing radiation. So even if for any reason you need to repeat it again, you can do it again because it's ultrasound. And sometimes also when it's because of the kind of size of fibroids that we see here, because we see sometimes this has been used for a uterus that's about 7 months pregnancy, and we planned to do it 2 times because of the number of fibroids, and the patient has had the second treatment also, and she's very happy with herself. So, and because it's not X-ray also, there's no damage to your ovaries, so you can have babies after. And of course, it's cost effective, no hospital stay, no blood transfusion, in places where HIV is very rampant, no risk of HIV. And this complication rate is very, very low. Now, the next question we get is HIFU for everybody? Because, I think some doctors are looking at it and saying, oh, this guy wants to take bread off our table. But you don't need to fear. The first thing is that it's not for everybody. It cannot be for everybody. Even open surgery is not for everybody. We just heard now about submucous fibroid. Any doctor who is going for submucous fibroid through open mammectomy is not doing a good job. That's what Dr. Ajayi was saying, that you can, if you have submucous fibroid, your best way to get to it is hysteroscopy. So this is not for everybody. And we try to look at it for 2 forms of contraindications. The relative contraindications, where when this is present, we know we need to be careful. It does not mean it cannot be done, but we need to be careful. And most of the time, what we do like a practice. We call it a simulation to see is everything going to go well, and then we have the absolute contraindications, which we cannot do at all. With the relative, obesity is a big problem with HIFU. So what we usually say is that when you're over 120 kg, then we need to do a simulation. because, and the reason is not far-fetched. You know, we said it only burns at the focus. Between the transducer and the focus, distance is usually 12 cm and 14 cm. So if, for example, the abdominal part is 10 cm, that means the only effective distance that we have is 2 cm. So imagine the fibroid is at the posterior part of your uterus, you will not be able to get there, and that's the way the distance that it needs to travel. For patients who had also had midline vertical incisions, we're a little bit wary. We need to do a simulation to see, can we have a safe acoustic pathway? Can the ultrasound pass without your bowel getting in the way? Because like Dr. Ajayi said also, when they're doing the laparoscopic surgery, the vertical midline incision is something you have to be wary of because the bowel might just be stuck to the incision. So the same thing with us. When we see midline vertical incision, we need to do what we call a simulation to be sure that there is no problem with your bowel. And then he also spoke about this pedunculated submucous fibroid, which is the type 0 fibroid. The best way to treat that fibroid is endoscopy. And the type 7 also, which is a subserous pedunculated, the best way to treat that is either laparoscopy or open. Because if we burn that, and then because of the stock, it drops into the abdominal cavity, then you can have infection, and we don't even want to have that. So with those two, we don't want to do HIFU. But sometimes we combine HIFU with endoscopy, but it's planned ahead. Then patients with abdominal liposuction, they're also a nightmare for us because the abdominal, to see the anatomy of the abdomen might be distorted because of all the scars that are already there. So we want to do a simulation before we take such patients on to see that we are not going to have any problem. Then patients who cannot take analgesia and sedation, we have a problem with them. So, and patients who cannot communicate, because we need you to tell us how you're feeling during the procedure, and that's where we can prevent complications. Because I'll explain to you a little bit how HIFU works, and then you will see what problems can come if you cannot communicate. Now, the absolute contraindications are mainly one, if you suspect cancer. Either there is ovarian, or we can see cervical cancer. And so one of the things we do a colposcopy to be sure that there is no cancer. Because we're not going to take any sample out of the fibroid. So we need to be sure that no cancer is present as much as possible before we do HIFU. And then the last one, which is an absolute contraindication, is if a patient cannot lie prone for at least 1 hour or 2 when the process is going to take place. Because you are actually supposed to lie prone for about throughout the process. So, and what you do actually is that you are lying on a table for about 2 hours, and you are lying in a bowl of water. So the water might get a little bit warm and sometimes also a little bit hot. You need to be able to tell us when it's too hot for you so that we can either stop it or so that you don't have skin burn. Or sometimes also when we are pulling the fibroids and the heat is passing, there is a basket of heat to your nerves, which is near the spine, especially for posteriorly placed fibroids. Then if you are feeling some pain in your legs, then you let us know so that we can change the direction through which we are hitting the fibroid so that we don't have foot drop or damage to the nerves after that. And that's why it's so important that you must be able to communicate throughout the procedure. Now, what I said is we want to go from present to the future. So what is the present? I think that's what we've been talking about. The present is mammectomy. whether it's laparoscopic, whether it's open, and we see that a lot of mammectomies are taking place in the country. Like I said, we're not saying that every person should be doing HIFU, but if you qualify for HIFU, then it's also an option that you can consider. But we know from what they've said also the complications that can arise from surgery, and as much as possible, HIFU can prevent this complication. So why do we need to also, for people who qualify, why do we need to continue to do the same thing? So that's why we're saying that we think that it's going to be, HIFU is going to give us that leap from the present to the future. And I like to, this is what Abraham Maslow's law of the instrument, and it says that if the only tool that you have is a hammer, every problem looks to you like a nail. So, and that's what we're trying to say now, that please, every fibroid does not need surgery. Now, let's compare the recovery period of this procedures. Ultrasound guided HIFU, 1 to 2 days. Hysterectomy, 4 to 6 weeks. Mammectomy, 4 to 6 weeks, abdominal. Laparoscopic mammectomy, 2 to 3 weeks. Uterine embolization, 1 to 2 weeks. I don't think it's rocket science. If I had fibroids, what I'm going to choose. But just wait a minute. I say maybe I'm not in a hurry. I want to take my time. Let's look at something else. What about this? What does your skin look like after the procedures? Dr. Victor Ajayi tried to bully us before. But we shall not agree. So you can see, I don't think this patient was done by Prof. Marco. No, you don't get that things like this. But this is the laparoscopy and then this is HIFU. It is no star at all. Now, let's look at, in Nigeria, we treated, I think yesterday, Friday, today is Saturday, okay, yesterday, they treated number 181. So let's look at the first 150. And Victor, see, we have treated more HIFU than even your laparoscopic mammectomy. And that's what I looked at when we were going for this. That the training for this is so short. The training interval is short. The learning curve is short. Instead of, because I was thinking of robotics or this, but something happened in South Africa. They bought a robotic, one hospital bought a robotic, and then they trained a surgeon, and then the guy after 1 year just left for Australia, and they had to lock up the they had to lock up the robotic. So I said, no, this is not going to happen again, because we're training doctors now. We trained 7 doctors. We just finished from different parts of Nigeria. Unfortunately, I don't think anybody came from this among the 7, but we were going to do this over. Actually, the Chinese doctor is still around. He was supposed to come with me today, but he's doing his PCR tomorrow, so that's why he's not here. So let's look at the first 150 patients. Out of the 150 patients, 124 had only fibroids. 20 of them had fibroids and adenomyosis. 6 had only adenomyosis alone. But 78 out of these patients, out of the 150, had associated infertility. Actually, that's one problem that I'm still battling with. How to, because I think Nigerians think that infertility, that fibroids is the cause of their infertility. So they want to treat fibroids without touching infertility. Or, some of them, I'm sure, when you finish your investigation, you see that the male factor has a problem. But when they're told that, oh, why don't you do your investigation for infertility? They say, no, no, let me get rid of this fibroid because as if it's going to be the one that's going to solve the problem. So we still need a lot of education for our patients. So 52% of them have infertility, and the age range is between 24 to 52. Now, this is instructive. When we finish burning the fibroid, we want to see what percentage of the fibroid will be able to burn. You can do this through two methods. Either you do MRI immediately after your procedure, or you do ultrasound with contrast. So what we do in the lecture is ultrasound with contrast after the procedure. And that gives you, when you're doing that, we call it ablation rate. That is what percentage of the fibroid you'll be able to burn. You are supposed to be able to burn at least 70% for the good shrinkage rate. What we've been able to burn in leg is 85% average. So I think we're doing a good job with that. The test of ovarian reserve, we're also compiling the figures for patients under 37. And we see no significant changes in the ALH of this patient. So it shows that the high food does not affect the ovarian reserve. And then we looked at the shrinkage rate. 91 had 3 months shrinkage, and we have 34% average reduction. 42, 6 months, 49%. 26 have had 9 months scan, 58%. 11 have had 1 year, 71.3 average. Now, out of these patients, the 150 patients, 30 of them had hysteroscopy. You know, Victor said that we do hysteroscopy for patients, whatever kind of myomectomy you have done before your infertility treatment, because we know that unless your endometrium is regular, whatever embryo you put into such a patient is a bloody waste of time. So we always do hysteroscopy. And what we saw is that only 7 of them had diagnostic hysteroscopy. 23 actually had submucous fibroid. And if you look at the figures that I showed us before, we have seen that about 15% of the patients that we see have submucous fibroid. So this is also this just rhymes with that. And I didn't see your figures until when you were presenting. That's when I noted it that, okay, this seems to rhyme. Now, these are the problems that we had after HIFU. I can tell you for free, the worst problem that we've had is this mild skin burn. And that is the commonest problem with HIFU. Skin burn is the commonest problem. But this did not require anything more than just dressing for a few days and then it was gone. The other things, abdominal cramps, all these intraoperative complaints are almost normal. And I guess it just will knock away the pain. Transient leg pain, after a few minutes it was okay. Lower back pain, and I just took it away. Yes, 18 had skin burning sensation, but only 1 of them actually had mild skin burn. Then after the procedure, 11 had heavy menstrual period that lasted for about 3 months before it stopped. And that is also not abnormal. 9 had watery vaginal discharge. Usually, patients who have this vaginal discharge are people who have submucous fibroids with what they have. So that's the reaction from the submucous fibroid. And but this one that had pelvic pain was a patient who had adenomyosis. And she really had a lot of pain. She came from Abuja. But the funny thing was that this patient will call and be crying and crying and crying. But I kept telling the doctor that we're missing something. There's something that we're not seeing here. She had depression. So until our doctor now in Abuja now put her on the drugs back, and then she stopped calling after that. So some of these things some of the patients that we see. Because I think a problem which she has not told anybody, or the husband is not cooperating with her, is that she really still wants to have a baby. This woman is already 47. She still wants to have a baby. And the husband is probably saying, no, no more babies. And so they have that conflict. But so it was the doctor she was taking it out of. She would just cry and cry and cry. And then until they started out until the person said, we didn't hear from her anymore. Yes, if we can play this, and then that will be probably the end of my.
My name is Selena Isori, and I'm 36 years old. I had my surgery done today. I want to say a very big thank you to Fibroid Care Center for this wonderful opportunity to go through this high-flow treatment. It was not really easy, but God took control. I just want to say a very big thank you for all the technologies that it brought to Nigeria, for making it easy for us to go through this process without stress, without pain, without blood transfusion, without pain at all. I just say may God continue to bless them in Jesus' name.
That was immediately put up. So, and I think that's what we think we can offer the patients now. Do I still have this? Okay, so my conclusion. HIFU is a safe option in the management of women with uterine fibroids and adenomyosis, especially when such women are desirous of preserving their fertility. The prevalence of uterine fibroids in women of reproductive age group and the emerging evidence of a shorter treatment to pregnancy interval compared to all other options calls for a larger clinical trial. Now, this is what I mean by this. We're seeing now, what we tell patients that if you're going to do IVF, wait for 6 months so that we can do a cystoscopy before you do IVF. But what people are seeing, people who are not doing IVF, is that a lot of patients are getting pregnant even about 3 months after HIFU, and they're doing well. But what we still say now is that, okay, wait for 6 months before you even start trying to get pregnant. So, but a lot of data is being gathered in that direction, that maybe we should cut it to 3 months. Because when they first started, it was 9 months. Now it's been cut to 6 months. Maybe it will be cut to 3 months. So that's what I think. Thank you so much for listening and questions.
Thank you very much, Doctor. Now, we are going to open the floor to an exciting question and answer time. So I'll go around the room and listen to questions from here first, then we'll go online and we'll then try and wrap up the meeting. So who's going first? All right, please introduce yourself.
Good evening, sirs. I'm Dr. Salawi, resident of Uterine here in Ibadan, OLA Africa Hospital. Thank you, sir. Thank you, Dr. Ajayi, for the wonderful presentation and this modern technique to treat uterine fibroid. I'm actually this is really exhilarating, I must say. It's very interesting. But I don't want to go straight to my few questions, sir. We were trying to describe how the procedure is carried out, the use of water. I didn't quite get that very clearly, actually. So probably a picture would suffice to just explain that. And then secondly, are there ways actually to prevent some of these complications? Because you mentioned the fact that the patient has to continually communicate when the procedure is being carried out. So, and that's most likely to be subjective. Some patients actually have very high pain thresholds. We may not really know when to say yes or no, and probably that may be the reason why some of these complications, arise. Are there objective ways to actually evaluate them during the course of the procedure, especially the thermal bond experience? Is there a way to regulate the temperature and all before we even have those complications ensuing? Thank you, sir.
I think you want to show a video or things like that.
Yeah, while this is looking for the video, what better objective way than talking to a patient? If she says she's hot, she's hot. If she says she's cold, she's cold. And you have to listen to her. But now one thing about HIFU is that HIFU is just a form of energy. How you direct it depends on whether you're using MRI or you're using ultrasound. Okay? With MRI, you can actually measure the temperature, but that's not all the problem that you can have with HIFU. Okay? Because the problem with MRI is that it's also restricted. For treatment of fibroid, you are better off with ultrasound than MRI because you know the MRI machine. Your movement is restricted, the transition movement is restricted. For these big fibroids, you're better off with ultrasound HIFU than MRI. Because we've seen also that MRI HIFU, your reintervention rate is higher than the ultrasound HIFU. So, for you to prevent complications, your best bet is to still listen to the patient. Yeah, they'll look for it and then, but the water is because ultrasound travels better in water than anything. So for the ultrasound to be able to travel, that's why we have the water. The temperature rising is because of fast cut out the heat. So that's, yeah.
Thank you, sir. So my question is, after I see where reoccurrence of the fibroid,
The occurrence of fibroids after HIFU.
Well, there must be a reason why you asked that question, but I don't think anybody used the word kill. I think I used that word kill too. Unless there's a resurrection. that fibroid is dead. But you might not be able to actually treat, because if a fibroid is less than like 2 cm, it might be difficult for you to burn it. You know? So, but bigger fibroids you burn and you can kill them. And the main advantage of HIFU is that it's probably the best treatment for treatment of adenomyosis, because it can burn off the adenomyosis.
Let's take that.
The HIFU knife, applied with FUS-focused ultrasound tumor therapeutic system, allows in vitro ultrasound to enter the body and focus on the lesion, killing only the tumor without destroying any healthy tissue. It doesn't cause a wound or the loss of blood, and patients usually make a quick recovery after treatment. So how, by a few clicks of the mouse, does a doctor finish the treatment? As an example, let's see how the treatment of uterine fibroids is accomplished in 5 simple steps. Step 1. Locate the fibroids. Unlike a laparoscope, which via hands-on operation reaches and views the fibroids, the HIFU knife uses B-scan ultrasonography to find the fibroids, including those a mere 1 or 2 centimeters in diameter. Now B-scan probe starts to move from the left side of the womb. Good! The left border of the fibroid is shown. Then we record its coordinate, +30. Then move the probe to detect the fibroid's right border and record its coordinate, -20. That's how we find a 5 centimeter fibroid and determine its position. Step 2. Make a treatment plan. A computer will help us plan out how to kill a 5 centimeter fibroid. This process is like cutting a potato in slices, except that it's done via a computer. Step 3. Contrast-enhanced ultrasound. Contrast agents are injected to determine blood perfusion, to estimate the level of difficulty in treatment, and to distinguish fibroids from normal tissue for comparison with the result of post-treatment contrast-enhanced ultrasound. Step 4. Treatment. Wait a minute before pulling the trigger. We need to make sure of 4 things. The proper condition of the patient, a safe acoustic pathway for ultrasound free of intestines, a safe water level and temperature. Focus the point of the HIFU knife aimed right at the target. Done. Now we can begin the treatment. Choose an appropriate degree of treatment, i.e. degree of thermal power, and destroy the fibroid slice by slice according to the treatment plan we made in step 2. Now that the fibroid has been killed, all the patient needs is a few painkillers as well as some music and movies. And there's no need to worry about B-scan ultrasonography images because our product is equipped with both 3D magnetic resonance imaging and B-scan ultrasonography to achieve precise positioning and treatment. Step 5. Second time contrast-enhanced ultrasound. Apply the contrast agents once again and we will find that the place where the fibroid once existed is no longer highlighted, which means the fibroid has been totally eradicated. That's the end of a successful operation. Isn't it easy and lovely without all the tiring procedures? Even though curing diseases is our duty, we do deserve a pat on the back from time to time. After the operation, nurse the uterus for 2 hours by cooling it down. Then the patient can begin having water, food and moving around. She will be able to return to work in 3 days. The residual fibroid will be cleared by the immune system. The patient will be able to get pregnant 3 months after the operation. The HIFU knife means hope for patients and is an important option for doctors.
All right. Good evening, everyone.
I'm Mrs. Olivia Oyafalayenka from Umaru Solo Yagari Foundation. My question is, during the eating period, will the fibroids shrink or is it come out?
Fibroids shrink or cover.
Yeah, thank you so much. That was actually something I was going to say. Because when Professor Amako was making his presentation, he made allusion to something, patient satisfaction. And I think that's one of the problems I have. Patients come in with the expectation that when, after I finish this thing, the fibroid will disappear. Okay. And it does not happen that way. The fibroid shrinks. And that's why I showed the shrinkage over 3 months, over 6 months, over 9 months, over 1 year. So that's one major, even with doctors. A doctor, we had an encounter with one of our patients who went to a doctor, and there was now an argument between the doctor and the patient. The patient was saying, the doctor said they didn't do anything for you. And the patient said, look, they did something, I did HIFU. Bring out the scan report before I left you. Bring out what I have now. So it was the patient now telling the doctor that the fibroid is shrinking. Because the moment the doctor did scan and saw, fibroid is here now. What is this? Let's go and remove it. So the fibroid shrinks. It does not, we don't remove fibroid. So, but we have had some people actually, another one, this just happened last week, and the patient called the doctor in charge of fibroid that she went to do one scan somewhere, and they said it. And she was supposed to come for 6 months scan. And said to the doctor that I'm coming to put trouble with you. You do anything for me. And then I think now the cousin also is a doctor, now said, look, why don't you go and do the scan? Let us go together. So they went to do the scan. And now the scan, the fibroid was about 8 cm when they did. Now it was 2 cm. So the doctor now said, but what? It's 2 cm. So she now came for the scan.
And she was now laughing and joking with the doctor. So the doctor said, "Well, you said you are coming to full trouble." He said, "No, but we have seen the fibroid has shrunken." So I think that's one thing, but we had that problem even with the stereoscopy. When we started doing the stereoscopy, I remember in Asaba, a patient went to do scan after doing the stereoscopic mammectomy. And the doctor said, "Wow, what did they say they did to you? Yeah, they scanned you, the fibroid is still here." But what we could only remove from the stereoscopic mammectomy is just the submucous fibroid. And we did that, and the woman got pregnant after when she did the IVF. So I think we need a lot of education for both doctors and the patients alike on what the technology can do and what it cannot do. HIFU does not remove fibroid, it shrinks. It kills the fibroid and it shrinks it. The people that love it the most are the people who have symptoms. Because you lie on the table with symptoms, you wake up and your symptoms are gone. So I think yeah, we need to understand that.
Going online shopping.
Thank you very much, sir. And it is for the new. Concerning going by the question you just answered, if a patient has, or if someone has a fibroid, significantly, the size of the abdomen. So by the time the thing is shrinking, I think the size of the abdomen should be reduced physically. Thank you, sir. Then, sir, no, I know this is particularly about fibroid. Can this method be used for some other non-cancerous growths? Apart from being a fibroid.
Yes, the first question that the size of the abdomen reduces considerably. We have some patients who have also come to do some catwalking in the clinic because now their clothes are and then, but what the second question you ask, actually, you know that this machine can be used for some cancers. We're just careful, we're introducing it. We want to do by next year, I'm sure, we're going to train oncologists on how to use this machine to treat, for example, pancreatic solid tumors. Because the guy who has it in Egypt, that's what is an oncologist, and that's what he does. So it can be used for some things apart from fibroids, but you just have to be selective about what and the data that is available to support what you're doing.
Says, what are the disadvantages of cryomyolysis as compared to HIFU?
Well, I don't know anything about cryomyolysis except that you're using cold temperature to do stuff. How effective it is, I do not have data because even for me to go for HIFU, I'd followed it for about 8 years. This was not how it started. Until when I saw that it was one, safe enough, two, it was effective. I had to go and see where they were using it. I went to Singapore to go and look at them using it. Then I went to China to go and meet them. And you know one thing, we think it's only blacks who have big fibroids. The Chinese also have big fibroids. They do have big fibroids as well. But this cryomyolysis, I do not have any information about that. But so I can only talk about HIFU.
Another question is, what's the relationship between the size and number of fibroids to HIFU treatment option?
Yeah, size is not a contraindication to HIFU. You can use it for almost any size of fibroids. The worst case, like I said, you might split your treatment into 2 parts. So maybe the patient is going to. We have 34 weeks. By the time the woman came, for the second trimester, it was already 24 weeks.
And so she just did the second one, so we're waiting to see what she will shrink into. So size is not an issue. What is an issue really actually is to take the patient holistically and look at what does the patient want. What is the game plan? Why are we doing this? For example, if she's doing IVF, she's using her eggs. After one HIFU treatment, will we be able to get access to our ovaries? Those are the questions we must be asking, you know. So I think it's just for us to do, and that's why I'm saying, but patients still don't get that. Because what we're trying to do is that the IVF center is different from the HIFU center. But for people who have infertility, you might need the two centers, you know, so that you can, from the get-go, you can take the advantage to plan your fertility treatment. But you know, Nigeria now, we don't trust one another. When you say you need to go and see fertility doctor, lie, you want me to go and pay another money there. So, but on the long run, it's better for you for our planning for your treatment. You know, so I'm still trying to see how we can make it attractive for the patients who have infertility. You can see about 52% of our patients have infertility. To have that advantage of you're not just getting rid of the fibroid and then you're coming back to start talking about infertility. And then, like, there is a particular patient that I had to see because the doctor was at his wit's end. So I said, look, madam, you have to do laparoscopic mastectomy because the fibroid is gone down, but we cannot access the ovary. And if you cannot access the ovaries, then there's no work done. So but the advantage of doing laparoscopic mastectomy now is that it's going to look like a bloodless surgery because the fibroid is already clear. So anybody can almost just remove that kind of fibroid, but it is still something that has to be planned. So I think the intersection between endoscopy and HIFU should make it very nice for our patients.
Another question is, what's the conception rate following HIFU in those with infertility?
Well, there's nothing like that because it depends on why you are infertile to start with. And that's what we're trying to correct. That people will think the moment either you do myomectomy or you do HIFU, that you're going to get pregnant. No, what about if the man's sperm is zero? Where's the pregnancy going to come from? So the most important thing is that, and you know, one thing we have also already seen also now is that there are a lot of women who have very huge fibroids who don't want to get surgery. And majority of them also have infertility. They are not even planning. I didn't see her. I spoke to a lady, 55-year-old. She had done myomectomy 2 times in the UK and Dubai. She had done embolization in South Africa. Now, so she's now bleeding again. And somebody said, go and do hysterectomy. And she doesn't want to do hysterectomy. So I said, okay, come, let's see whether you can do HIFU. Unfortunately, she doesn't qualify for HIFU because of those scars that they're giving her. And the people in the HIFU center now are enemy. It's because they can't treat her. But you know what we're saying is that safety first. I mean, there's no point burning your fibroids and then burning your blood at the same time. But what I'm trying to say is that we have a lot of women who have fibroids and they're keeping the fibroids to themselves because they don't want to get surgery at all. And majority of them have infertility. So it's important for them to have good assessments for their infertility even before burning the fibroids.
What has the weight? Federal 120. What does it have to do with it? What has that 120 got?
Yeah, it's just an approximate weight for the abdominal gap to see what they said. If the fat, the abdominal fat is so huge, then IQ might not be useful for such a patient. So if you are, so what we do is we do a simulation. We don't just say because we are 120, we cannot touch it. We do a simulation and see if the fibroid, for example, if it's an anteriorly placed fibroid, so we might be able to teach it. So,
Prof, some questions are still coming in for you. Please, what's the standard regarding use of HSG before and or after open anatomy?
Thank you very much. I'll answer that question because sometimes HSG is done to see if there is if the tubes are compromising fertility. And then of course if the fibroids are compromising, if the fertility is compromised, and of course medical legal reasons. So that the patient doesn't say after you treated me that fallopian tubes are not protected anymore. And it's always good to do HSG before and most times after they be lucky the patient after the patient is able to subsequently get pregnant with this one second after.
Another question is that can adenomyosis be excised from open surgery, just like open mammectomy? The fibroids removed during mammectomy grow back, or it's the little unremovable ones that grow bigger?
Thank you very much. Yes, adenomyosis can be excised, but like I said, you have to be careful not to take out most of the uterus because some men can be extensive through most of the layers of the uterus. The second question was, can they grow back again? Usually when you take out fibroids, like I said, the patient may be predisposed to fibroids. So you may be lucky to, if you want to choose to take out everything, the tissue may be already predisposed to it. So a few times we have recurrence, but not as if the fibroids that you took away are the ones that are doing it. They're doing it.
Comment from Dr. Vipaja.
For adenomyosis, the importance of making a diagnosis before going where possible should be considered. An MRI can help. Ultrasounds also can differentiate because MRIs are available and they can help because some of these repeated surgeries we keep doing, I think Madam mentioned it. Actually adenomyosis and we think it's fibroid. Where they are not seeing anything, he goes to another doctor, they cut again, and this is giving the uterus damage. So better to try to differentiate between adenomyosis and fibroid because they present similarly, and you should differentiate them so that you know the best option for the patient, one of which is fibroid.
Thank you very much, Doctor. This question, Dr. Abayomi Ajayi, this is, please can you shed some light on the eligibility criteria for HIFU, part 1. The second one is, if it shrinks, will it finally disappear? If not, will there be need for open laparoscopic surgery?
yes, I think one of the things that we need to understand is that do we want to remove fibroids or do we want to have quality of life? Do we want to, that we're symptoms free? Those are some of the questions we need to answer. Like Tayo said, you see 2 cm fibroid and the patient does not sleep overnight because the doctor said, I pity doctors, and this is what I mean. You see a 2 cm fibroid, you keep your mouth shut. Okay. Then she goes somewhere else, and the patient, hey, fibroid, and then she comes back to you. You don't even know anything. You did a scan, but really and truly, why did you say probably you didn't say anything? Because it was not significant. Now I seriously don't know where to belong to in the truth. Kind of thing you lose. So with patients, but I think doctors we need to continue to educate our patients on the fact that it is not every fibroid that needs to be removed. Professor Coker of, I don't know whether any of you knew him, of blessed memory, he was my teacher in Lucy. He say that don't trouble unless trouble troubles you. You know? And so I think that's the case with fibroids. If it doesn't trouble you, let it be. But tell the patient. I think the patient should know. One, for follow-up, so that we can. But sometimes some of them are just so difficult because they will go on about it. But I think we should still tell. Now, whether the fibroid, you don't want, it's not that the fibroid should completely be removed. That's not your point. The point is that you should not have symptoms. Your point is that if you want to get pregnant, you can get pregnant. For example, like when we do hysteroscopic mastectomy, we don't get rid of all the fibroids, but we achieve what we want to achieve, and that's it. So, but it's important for us to take the patient, carry the patient along. So, and that's why the patient will also defend us with that doctor who was saying that they didn't do anything, because she understood. So, I think it's very important for us to spend time with the patients and explain things to them. Majority of them will understand.
Right? Anything around the room? Any questions? Are we done? Let's check. Some more questions online. Oh, right.
Well, I am asked to introduce myself. My name is Shade Oguntola. I'm the health editor of Nigerian Trading. So my question might sound novice to you, might sound strange. But you kept on saying that in all the cases that you deal with people, that it is something hard infertility. Can we, from the layman's perspective, say that the problem, that the fibroid was the cause of the infertility? Under what situation can you say, yes, it's for infertility, the infertility is as a result of fibroid? Out there is a common thing to say, I'm infertile because of fibroid. And is there a link? Is there a cause and direct thing?
Yeah, very interesting question. Well, let's say stay from the get-go. Fibroid does not cause infertility, no causal relationship, but there is an association. The association, I think, there was a study that was done in UCH in the 80s. I remember Dr. Obed was part of the people who did that study, and they found an association between fibroid and additions. Whether that is the cause, we don't know, because adenomyosis also might be one of the things that we're seeing that we say there are additions, so it's possible. But we just say we don't know how they are related. But we know that about 20% to 25% of patients with infertility have fibroids. But it is only 1 to 2% of patients who have infertility due to fibroids. So we don't, and doctor, I think you explained it. Those few people, because there is a problem with their tubes from the fibroid, either is blocking the tube, something of that nature. So when people, but in our environment, people, I think it's the association that they look at, which is more pronounced than as a cause. Because when we look at these patients, we will see that some of them also have other reasons why they are infertile. But fibroids is usually because it's so obvious, your tummy is protruding, so it must be the thing that is not making you to get pregnant. But doctors, I don't think doctors are doing that.
Doctor, some very exciting questions is, how soon post-hypo can the patient try for conception?
Anyway, what we recommend now, if you listen even to the video, they cut to 3 months. But for IVF, for those of us who do IVF, patients who need IVF, we still say, okay, 6 months. But we know that 3 months is okay. You know. But if you get pregnant spontaneously, of course, nobody can stop that. Even if you get pregnant the next day, I'm well alone.
We have another question. It says, can hypo be used regardless of where the fibroids are?
So, IFO cannot just be used anywhere. A patient is to qualify to be able to use IFO. And we've spoken about it, especially type 0 and type 7 fibroids cannot, hypo cannot be used for sex.
I think we are satisfied according to Idiamin. We are well fed. We are fed up now. All right, I think the evening has gone pretty well. So I've taken the audience of Dr. Victor Ajayi, to thank everyone who has come. And
thank you, everyone. It's been a pleasure having you. We won't forget our online audience and those in the hall there. It's been a pleasure talking to you about fibroids, and I hope that we have taken something from this presentation, that fibroids are a common problem in our women. Not all fibroids need treatment, and if they need treatment, there are several options. Some may be open surgery, it may be laparoscopy, it may be hypo. So the doctor will evaluate you and will recommend the best option. So thank you very much. Those in the hall, I would say safe trip to your various destinations. Those online, thank you for joining, and we hope to do this again with you. Thank you.
thank you very much, everyone. Have a wonderful evening.